Hello, my name is David Henderson. I'm going to talk a little bit today about factors associated with unplanned admission to hospital. I work at Edinburgh Napier University and the Scottish Centre for Administrative Data Research. I'd like to acknowledge my co-authors and the various institutions that they represent and shown here on the slide. What I'm going to report today builds on a data set that was created as part of my PhD research at the Urban Big Data Centre. High-income countries are seeing older people making up an increasing proportion of their populations, and this is having an effect on the demand for various services. One of the most important of these being what we term in the United Kingdom as social care services. Quite often internationally, this is referred to as long-term care. And these are a range of services that can be provided at home and institutions or via cash benefits, and they comprise assistance with personal activities of daily living and instrumental activities of daily living. Historically, there's been very poor data collection in this area, and it's therefore under-researched. One of the most important things we don't know is about, or have very little evidence of, is the interaction between health and social care services. With this data set, we've previously shown a link between receipt of social care and multimorbidity, which is something which may seem quite intuitive, but we believe this is the first empirical evidence of this, and therefore quite important. We're now aiming to build on that research, and we are specifically today going to report on identifying risks for unplanned hospital admission, taking account of social care receipt and multimorbidity, and also socio-demographic factors. I should add that I lost access to this data set in March 2020 due to the COVID-19 pandemic. I couldn't access the safe settings for this, so therefore these are only now preliminary results. I haven't been able to do any work on that over the last 6 or 7 months. However, I think there's still some important stuff that we can share with you today. So this is a retrospective observational study, and it includes all individuals over the age of 65 in Scotland in the financial year 2015-16. So it's about 879,000 people. We linked the Community Health Index Central Register, which is a list of all individuals registered with a general practice in Scotland, which you need to be to access health services, and it's therefore comprises virtually the entire population. And with our over 65s cohort from there, we linked all community prescribing information, from which we derived a proxy measure of multimorbidity. I'll talk a little bit more about that in a minute. We also linked the unscheduled care data mark, which comprises services that are used in the out of hours period, so after 6 p.m. at night and before 8 a.m. in the morning and at weekends. There are a number of services listed in here, but we're most interested in unplanned admissions to hospital. And also we linked the social care survey, which was collected by the Scottish Government between 2010 and 2017 at individual level, and lists the types and amounts of social care delivered to individuals by local authorities in Scotland. For our measures, we measured time to first unplanned hospital admission in the study period in days. So T0 was 1st of April 2015. And our main independent variables of interest are social care, measured by presence of the social care survey in the financial year prior to the study period, so 2014-15. And also our other important variable of interest is multimorbidity. And as I mentioned, that was derived from prescribing data, and we count the number of BNF chapters that an individual has repeated medicines prescribed from. The BNF is the British National Formulary, and it's a list of all the medicines that can be prescribed in the United Kingdom, and it's split by body systems, so by respiratory system, cardiovascular system, digestive system, etc., etc. So it gives us a crude measurement of the number of body systems that an individual is getting treated with their medications. There's a few studies have shown that a count of prescribed medicines is a very useful measurement, proxy measurement of multimorbidity. We've used this measure in the past and found it to be pretty robust. We also adjusted for age, sex and socioeconomic position. We measured the latter by the Scottish Index of Multiple Deprivation, which is an area-based measure, and we split the population into deciles of deprivation using this. We plotted a couple of Meyer curves and compared those with and without receipt of social care, and also fitted Cox proportional hazard models to determine hazard ratios for our independent variables. So for results, this is our first table, and in this column we've got our total cohort, and in this column we see just those that are admitted to hospital. We noted here that 55% of those admitted to hospital were female, which is similar to the overall population over 65, but those in older age groups were more likely to be admitted to hospital. So for example, 19.8% of all those admitted to hospital were aged 80 to 84, whereas in the total population of the cohort, they only make up about 13.8% of that population. In terms of deprivation, we see that those in the most deprived decile made up 11.5% of those admitted to hospital, whereas those in the most affluent only made up about 7.6%. There's an almost linear trend as that goes up, from moving from most deprived to most affluent. In terms of social care receipt, those that were admitted to hospital, 30%, almost a third of those were in receipt of some form of social care, compared to just 13% in the overall population. And for multimorbidity, the more severe multimorbidity made up a much greater proportion of those admitted to hospital. Almost 27% of those admitted were prescribed medicines from 6+ chapters of the British National Formulary, and that, like I say, is an almost linear increase. Only 4% of those admitted had no previous prescribing. About 6% of those admitted were resident in a care home. And we also measured prior admission by looking at the financial year previous to our study period and seeing if anyone had an admission in that financial year. I'm not entirely sure that this can be a useful variable for our models. They're very small numbers. I'd like to look at the accuracy of this measure just to determine whether it is going to be of any use in our models. I think these may be some spurious results, and I'd like to do a bit more work with that variable. So with our Kaplan-Meier curve, we split this by those that did not receive social care and those that did. And we know at 1 year that those that received social care, only 64% of those receiving social care remained admission-free at 1 year, compared to 88% of those that did not receive social care. A noticeable difference, and unsurprisingly, a statistically significant one as well. We have our numbers at risk table at the bottom here. And for our, from our Cox proportional hazard models, we fitted univariate and multivariate models. In this model, the multivariate model is adjusted for all the other variables that you see here. So in that model, we find that those in receipt of social care were 2 times more likely to be admitted to hospital compared to those that were not. Females were less likely to be admitted, and there's an increase with age, unsurprisingly, for those admitted to hospital. Those in the 90 to 94 age group, about 2.5 times more likely to be admitted to hospital. Similarly, in terms of deprivation, we find those living in the most deprived decile were 1.5 times more likely to be admitted to hospital compared to those in the most affluent. And those with the most severe multimorbidity with prescribing from 6+ chapters of the BNF were 4 times more likely to be admitted to hospital compared to those with no prescribing. We'll note a change in the direction of the effect for those living in a care home after adjusting for all the other variables that you see here. I would treat that with some caution. I think this model is overfitted. We should probably get more informative results just by adjusting for age, sex and deprivation only. And that, I think, would, although it may attenuate the univariate model, I don't think it would change the direction completely. As I said at the start, I think this study needs a little bit more work. We need to do a bit more work with our modelling before we would be publishing this. But still, I think these are quite interesting results as we go along. This is our the variable that I'm still a little bit unsure about whether we should be including at all. So just to talk the limitations, this is a descriptive study. We're not identifying any causal links here, and these are preliminary results. Like I say, this model is likely to be overfitted. We also know that there's some misclassification present in the social care survey. We don't capture everybody, although we think that misclassification may be quite small, and we do know it's not entirely 100% accurate. And similarly, for those that are living in care homes, the Chi flag, although sensitive, although very specific, it's not very sensitive. So we'll be missing some people that live in care homes also. Also, we used a proxy measurement of multimorbidity. We feel it's quite a robust measure. However, it doesn't disguise the fact that the most accurate way of measuring multimorbidities would be with disease data from primary care. This data is very difficult to get a hold of and link at national level, and therefore we have to rely on proxy measurements. And just to conclude, these are preliminary results only. Please treat them with a bit of caution, but there is some tentative evidence that there's an association between social care receipts and unplanned admission to hospital. And this would be a very important finding if we can confirm it in the context of the integration of health and social care services here in Scotland and the implications that that may have for that. Also, we need to really improve our social care data collection, not just in the United Kingdom and Scotland, but internationally as well. This is a poor area and under-researched that's been really highlighted during the COVID-19 pandemic. We should be trying to improve that internationally. So with that, I'd just like to thank you for your time, and I will finish my recording here. Thank you.